Appropriate practitioners. Originally, for prescribing, there was only 3 people who could prescribe independently. That's a doctor, a dentist and a vet. Now we've added in community nurse practitioners who can prescribe from a very limited formulary, and that's called the V100. And now, in the last couple of years, we've added on other community nurses who aren't specialist practitioners who can do the V150 course, again using the same formulary as those other specialist community prescribers. But a very limited formulary. That's either available as a little booklet just for the nurse prescribing formulary, or it's listed in the back of the BNF. You can see the community formulary. There's also now the nurse independent practitioner and the midwife independent practitioner. Pharmacists, optometrists and optometrists are also independent practitioners, but with the caveat that they cannot prescribe controlled drugs or the limited range of controlled drugs available to the nurse and midwife independent prescribers. And then we have the last group of prescribers, which is supplementary capacity only. That means they cannot prescribe without a clinical management plan and the partnership of an independent prescriber, i.e. doctor or dentist. And at the moment that covers podiatrists, physiotherapists and radiographers. Nurses and midwives in some instances, and pharmacists in some instances, may find that they need to prescribe in a supplementary capacity rather than independent prescribing capacity, depending on the licensing of the drug, product license issues, or prescribing off-label, maybe controlled drugs, or they may not feel competent to prescribe, but they're developing a competency for a new area, and it's supplementary prescribing is a very good stepping stone to develop that competence as well before you go it alone, take full autonomy in terms of being independent. NHS regulations, or see the MHRA for this as well. There's various other caveats within what can be prescribed. For example, blacklist is one category. This is a list of substances that are not prescribed under NHS pharmaceutical services. So if a pharmacist should dispense one of these blacklist drugs, they won't be reimbursed. An example of this we've got on the slide is Otrivine nasal spray, but there are others, and it's probably useful to familiarise yourself with those drugs that are blacklisted, because one, you're prescribing illegally, and two, the pharmacist won't be reimbursed, and the pharmacist has a tough job having to spot these things coming through, because obviously they won't be reimbursed, but also they'll be passing a prescription, taking a lot of responsibility for that prescription when they shouldn't. Then there's the borderline substances, and these are ones that the NHS consider aren't so suitable for prescribing, and will only pay out to the pharmacist if the Advisory Committee on Borderline Substances approves that they are regarded as drugs. And these sorts of things may be specialised enteral feeds or supplements, for example. But again, try and familiarise yourself with what these products are. If you have a look in the drug tariff, which is available online, there is a hard copy produced every month, but again, it's a very large document for those of you who've seen the drug tariff. But it's worthwhile having a look online for the electronic drug tariff, because it gives you a list of a lot of these borderline products that you shouldn't prescribe, such as blacklist drugs, and also it's the most accurate source of costs of drugs. The BNF is only produced biannually, so the costs may be out of date. And if you're working in an area where you need to know pack sizes of things, particularly certain specialised dressings and things, it's a very good resource to use to find out what products are packaged at, how many come in a pack, how many dressings are available, and gives you a good idea of the cost. So it makes you think hard about, should you be prescribing that product, or is a cheaper one that you might prefer to prescribe because of the cost when you actually see the actual amount that some of these things cost. It can be quite scary. And then the other regulatory thing to watch out for is black triangle drugs, and these are actually denoted with a black triangle next to the drug in the BNF. And these drugs are newly licensed, so they've got their marketing authorisation, they're new on the market, but the MHRA are wanting us to be very vigilant and watch out for side effects that they may not have encountered in their trials. So as I said earlier in this presentation, although drugs have gone through this rigorous process of many, many years to get their marketing authorisation, the individual experience of a drug, which may not have been experienced during the trials for whatever reason, not just children, but certain ethnic groups, for example, certain age groups and so on, may have a different response, or other drugs they may be on may throw up a different response than those that have been met during the early days of the trials. So these drugs are denoted with a black triangle so that any unusual effect is drawn to the MHRA through the adverse drug reactions yellow card scheme. And remember, that can be done either using yellow cards in the back of the BNF, it can be done online, and you can do it, doctors can do it, and patients themselves can do it if they experience a side effect. And it just builds up that pool of knowledge of the side effects of particular drugs. So who can prescribe what? Those of you who are independent prescribers or are aspiring to be independent prescribers are fully responsible and accountable for your prescribing decisions. So you really need to know exactly what you're doing and be sure that you've taken all steps to be safe and accurate. That includes an accurate and comprehensive assessment, you come up with the correct diagnosis, and that you are absolutely clear about the plan that you're going to put in place, the drugs you're going to choose, that you're basing it on evidence, on guidelines, local protocols, etc. There's sometimes limitations of what you can prescribe. You can't, as we've said, you can't prescribe the blacklisted drugs, and we've already referred to certain CDs. So for an independent, in an independent capacity, some CDs you can prescribe, but only for certain conditions and maybe through certain routes. So you need to be very, very careful that you know exactly what they are and don't prescribe outside of what you legally can prescribe. And it's particularly pertinent for nurses working in palliative care or end-of-life care. So legislation on prescriptions. Prescriptions, going back just to the fundamentals now of prescription writing. They've got to comply with the Medicines Act to be legally valid, and the regulations that are from the Medicines Act. And if an invalid prescription is completed by a pharmacist, it's actually a criminal offence. So it's still a real pressure on pharmacists to constantly be checking all prescriptions. And those of you that have worked behind the scenes in the pharmacist may be gaining experience of seeing what happens to a prescription once it's been written. A very valuable experience, which I highly recommend. It's an incredibly pressurised job, and you maybe see it in a big pharmacist where there's lots of dispensers working, and the pharmacist is taking that full responsibility, having to check what the dispensers have got out of the drawers, put together, ready for the pharmacist to check. It's quite an onerous task from my experience of watching pharmacists in action. And I think it's useful to bear in mind, depending where you work, if you're working in a big hospital, pharmacists have got this legal responsibility, and it seems like an age sometimes for drugs to get back to the ward, to get out to patients who are waiting to go home, but they have to comply with this process and to be safe, to make sure that it's safe for the patients. They've cross-checked things. Sometimes there may be queries, they may have had to check queries, they may have had to look things up, and they've got to be sure, because they are holding a lot of accountability themselves for that prescription, along with the prescriber. So the actual prescription itself, there's certain things which are a legal requirement. You can find that in the early section of the B&F. It's right near the beginning. It says how to write a prescription. So you must ensure that you meet the legal requirements. There's no negotiation on that. It doesn't matter what type of prescription you're filling out, whether it's a hospital drug chart, an FP10, one that's going to a community pharmacist from a hospital, a prison prescription and so on. The legal requirements are the same for all. There are other elements which aren't legal requirements, although you may be surprised to find that they're not legal requirements, but they are good practice. And I think when you're considering what the implications of some of those things that are recommended for good practice, if they're not on the prescription, that I think will focus your attention in terms of how you write prescription compliant both with the legal and good practice guidance. You need to look at what's happening locally. Obviously, there are so many different prescriptions that you need to find out what's required where you work for the prescriptions you're going to be using. And look at the Department of Health guidelines alongside the B&F guidelines as well.